Welcome to the Deep Dive. We take a stack of sources and pull out the essential knowledge you need to be well-informed, fast. Today, we're taking a deep dive into the critical and often debated world of CPR and emergency cardiovascular care.
That's right, and we've gathered quite a collection of material here. We've got excerpts from the 2020 AHA guidelines, highlights these really synthesize the science from ILCR, that's the International Liaison Committee on Resuscitation, plus contributions from the Heart and Stroke Foundation of Canada.
Go.
We also have the actual algorithms for things like, bradycardia, tachycardia, cardiac arrest. There's a specific review article looking really deeply at the evidence for epinephrine, notes on ongoing controversies, mechanical CPR, defibrillation, that kind of thing. Some learning objectives, and importantly, a specific randomized trial from JAMA in 2021 focusing on vasopressin and methylprednisolone. Quite a bit to cover.
Okay, yeah, let's unpack this. So our mission is to extract the most important insights and updates from all these sources. We really want to give you a clear picture of the current state of resuscitation science and practice, and highlight some key areas where the evidence is complex, where things are still being debated, and where the field is evolving, particularly when it comes to the medications we use during cardiac arrest.
Yeah, it's definitely a high-stakes topic.
For sure, but we'll navigate it together.
Okay, so to set the stage, let's start with the context of those 2020 AHA guidelines. These guidelines, they represent a pretty massive undertaking. It's a comprehensive revision across adult, pediatric, neonatal life support, but also education science, systems of care. It's broad.
And it wasn't done in a vacuum, right? This is a huge international collaboration. You mentioned ILCR, Heart and Stroke Canada, bringing experts together globally to sift through the latest science.
Absolutely. And within these guidelines, they use a structured system to grade the strength of their recommendations and the quality of the evidence behind them. You'll see these abbreviations, COR for class of recommendation, LOE for level of evidence, so like a class 1 recommendation. That means the benefit strongly outweighs the risk. And LOEA, that's the top-tier, high-quality randomized controlled trials, ideally backed up by other studies, the gold standard.
Gotcha. And here's where it gets really interesting, maybe a little surprising right off the bat. Out of all those recommendations, 491 specific ones across all areas in the 2020 guidelines, only a tiny fraction, what was it, 1.2%, are based on that highest level A evidence.
Just 1.2%, that's right.
Wow.
Only 6 recommendations out of almost 500. That number is really striking. And it just underscores the immense challenges in doing high-quality research and resuscitation. I mean, think about it. The chaos, the high stakes, getting those definitive, large-scale randomized trials, incredibly difficult.
Only 6 recommendations with that gold standard evidence. That really puts it in perspective. It explains why so many recommendations end up based on lower levels of evidence, like CLD. That's limited data. Or even CEO, which is basically expert opinion.
Exactly.
So the guidelines are built on the best available science, but we have to acknowledge that science isn't always, rock solid certain.
Precisely. And that inherent uncertainty, it's really important to keep in mind, especially as we dive into some of these ongoing controversies where the evidence just isn't perfectly clear-cut.
Right. Okay, so before we get deep into those medication debates, let's quickly touch on a few key updates across the different age groups, just for context.
Sure. So for adults, there's a strong re-emphasis on just how critical early bystander CPR is. Get those hands on the chest. They've also streamlined things a bit, combining the BLS and ACLS guidelines. And unfortunately, the data still shows that outcomes for in-hospital cardiac arrest remain significantly better than for out-of-hospital cardiac arrest. Still a major challenge there.
And for kids. Causes are different, often respiratory, right?
Often, yes. And a notable change here is an increase in the recommended assisted ventilation rate. It's now 1 breath every 2 to 3 seconds.
Okay.
So that worked out to 20 to 30 breaths per minute. And that's for all pediatric resuscitation scenarios, pulse or no pulse.
Interesting.
They also now suggest using cuffed ET tubes more readily and specifically recommend against routine cricoid pressure during intubation. That's a definite shift.
Got it.
And something really important, across all age groups, including kids, there's a much stronger focus now on recovery. It's not just about getting ROSC, return to spontaneous circulation in that moment.
Right.
It's about supporting the physical, the cognitive, the psychosocial needs of survivors long after the event itself. A more holistic view.
That makes sense. And newborns.
For newborns, the sources really stress that every birth needs a caregiver trained in those initial resuscitation steps. Absolutely crucial. The #1 priority. Getting inflation and ventilation of the lungs, that comes first. Umbilical vein is the preferred route for vascular access if you need it. And a significant update here is introducing this idea of discussing cessation of resuscitation efforts around the 20-minute mark if there's been absolutely no heart rate response despite really effective interventions.
That 20-minute time frame.
Yeah.
That must provide some much-needed guidance for those incredibly difficult conversations.
It does. It gives a point to pause and reassess.
Okay, let's get to the core discussion now, the medications used in cardiac arrest.
Yeah.
This is definitely where we see significant debate and evolving understanding based on these sources.
It really is. And the drug everyone immediately thinks of, epinephrine, adrenaline. The 2020 guidelines reaffirmed its use and the timing. Basically, give it early for non-shockable rhythms, PEA, asystole as soon as you get IV or IO access.
Right.
For shockable rhythms, VF, pulseless VT comes after the initial defibrillation attempts haven't worked.
And the rationale they give in the highlights is based on evidence, including those 2 big randomized trials, over 8,500 patients total, showing increased ROSC and overall survival.
Yes, and this is precisely where the conversation gets complex. That first 10 EM review article really digs into this exact point. Because while observational data and now these RCTs show epi increases ROSC, gets more people admitted to the hospital, they consistently fail to show an increase in neurologically intact survival.
Right, saving the brain. And that large Paramedic 2 trial you mentioned is key here. Over 8,000 patients.
Huge trial.
And it confirmed a small, statistically significant benefit in overall 30-day survival. Was it 3.2% versus 2.4%?
That's right. A small difference, but statistically significant.
But, and this is the kicker, it found no difference in survival with a good neurological outcome between the epi group and the placebo group.
Exactly. No difference in meaningful survival, you could say. So the reviewer in that article argues, okay, given this lack of brain benefit, plus potential harms, resource costs, people dying in the ICU after prolonged stays, or surviving with a severe disability, the routine use of epinephrine might, from a truly patient-centered view, actually cause more harm than good. The reviewer even suggests it could potentially be removed from routine algorithms, though, keeping it for specific situations like anaphylaxis or maybe profound PEA where it might directly target the cause.
That's a really challenging perspective. It forces us to ask, is just restarting the heart the main goal, or should it be survival with good brain function?
That's the fundamental question.
It seems the guidelines lean on the overall survival data, but some experts are really highlighting this critical lack of neurologically intact survival benefit. That's the tension, isn't it?
That's the tension, absolutely.
And just to be clear, high-dose epinephrine, still a no-go.
Definitely still a no-go. The sources confirmed that's not supported. Older trials even suggested harm. Routine high-dose epinephrine is out.
Okay.
But yes, that tension between ROSC overall survival versus meaningful neurological survival, that's the heart of the epinephrine debate right now.
Okay, moving on. Another medication combo that's generated buzz, vasopressin and steroids.
Right. We knew from older trials that vasopressin alone didn't beat epinephrine for survival. But then the idea emerged. What about combining vasopressin and a steroid, specifically methylprednisolone, with epinephrine, particularly for in-hospital cardiac arrest?
And there are those Menzelopoulos trials, 2009-2013.
Yes, those were quite influential. And they looked really promising at the time. They found a significant improvement in favorable neurological outcomes with this combination therapy. The larger 2013 trial, for instance, showed something like 14% favorable neuro outcome versus only 5% in the control group. That got people's attention.
Yeah, that sounds like a potential breakthrough, improving the outcome we really care about, brain function. But then came that more recent Anderson trial, JMA 2021. Larger trial, also in hospital arrest. What did that one find?
Well, the Anderson trial confirmed one part of the earlier findings. The combination therapy did significantly improve ROSC rates 49% versus 34%, so better at restarting the heart initially. However, and this is where it directly conflicts with Menzelopoulos on the brain outcome, the Anderson trial found no difference in survival at 30 or 90 days. And crucially, no difference in the rate of favorable neurological outcome.
Wow. Okay. So conflicting data on that critical long-term neurological recovery piece.
Exactly.
The combo might help restart the heart more often, maybe, but the latest large trial doesn't show it helps patients survive long-term with good brain function.
Right.
The controversies notes mention this combo is sometimes considered reasonable, maybe like a kitchen sink option when nothing else works.
Yeah.
But that conflicting evidence makes the decision, well, less clear-cut.
It really does. It's a perfect example of how complex resuscitation evidence can be. Improving ROSC is one thing, but ensuring that translates to a meaningful long-term outcome for the patient. That's the persistent challenge.
Makes sense. What about other meds, antiarrhythmics?
Sure. Based on the algorithms and sources, amiodarone or lidocaine are still the mainstays for shockable rhythms, VF, or pulseless VT that just keep going despite initial shocks, good CPR, and epinephrine.
Okay.
Esmolol is also mentioned as something to consider for really stubborn, refractory, or frequently recurring VF.
And the others sometimes mention magnesium, calcium, bicarb. Do they play much of a routine role?
Generally, no. The sources really emphasize that unless you're treating a specific identifiable cause, like the classic H's and T's, maybe severe hyperkalemia where calcium is indicated, or perhaps bicarbonate in specific overdose situations, these drugs play a pretty minimal role in routine cardiac arrest management.
So the focus stays on.
Focus stays on excellent CPR, early defibrillation for shockable rhythms, and timely epinephrine, despite the ongoing debates about its ultimate benefit.
Got it. Okay, beyond meds, there are other important updates and controversies. Mechanical CPR devices, for instance.
Right. They have some obvious potential advantages, don't they? Consistent compression quality, frees up team members, allows CPR during transport or shocks.
Yeah.
And they can definitely be useful in specific situations, prolonged extrications, maybe hyperthermia, long transports. However, the evidence when you compare them head-to-head against high-quality manual CPR, it's mixed. Some studies show benefits, especially maybe in hospital, but for out-of-hospital arrest, the data is less convincing. It hasn't consistently shown a clear advantage over really skilled manual teams.
And the training piece must be huge. Getting that device on quickly, without pausing compressions.
Absolutely critical. If you have long pauses putting it on, you lose any potential benefit right there. Teams need to be slick with deployment.
Okay, another area. Defibrillation strategies. Double sequential defibrillation, or DSD, sometimes called double dumping.
Yeah, the AHA guidelines explicitly state they do not recommend routine DSD.
Okay.
There was that DOVE-VF pilot trial mentioned in the notes, which was interesting. It suggested that just changing the pad position, what we call vector change, might be as effective as DSD for getting ROSC.
Interesting. But the impact on long-term neurosurvival from that? Yeah. Still unclear.
Still unclear. And it's emphasized that DSD, if you even consider it, is for refractory VF, meaning it hasn't responded after like 3 or more standard shocks, not just for VF that comes back.
Got it. Refractory, not recurrent.
Yeah.
What about airway management? Big shifts there over the years.
Huge shifts. The priority now is firmly CAB. Compressions, airway, breathing. Get those compressions going. Defibrillate early if it's shockable. Then worry about the advanced airway.
And surprisingly, maybe pre-hospital intubation hasn't really panned out in terms of improving outcomes in out-of-hospital arrest compared to simpler airways.
Correct. Compared to good bag mask ventilation or supraglottic airways like an LMA or iGel, the sources say placing a definitive airway like an ET tube is reasonable if the provider is highly skilled, and this is key, can do it while compressions are ongoing.
Never pause compressions for intubation.
Absolutely never pause compressions for the tube. Supraglottic airways are a great alternative if intubation is tricky or would cause delays.
Makes sense. And waveform capnography, essential.
Essential. Non-negotiable, really. It confirms your tube placement, obviously, but it's also a vital real-time indicator of CPR quality.
How so?
If your ETCO2 number starts dropping, your compressions might be getting weak or ineffective. If it suddenly jumps way up, that can be your first sign of ROSC.
Ah, okay.
And a really key point, avoid hyperventilation. Bagging too fast or too hard is actually harmful, reduces blood flow back to the heart.
Right, got it. And briefly, sedation during CPR, that's being looked at.
Yeah, the sources just touch on it. Using agents like ketamine during CPR is being explored. The idea is maybe preventing patient awareness, which can happen, and potentially offering some brain protection. But it's early days, clinical trials are ongoing.
Okay, so shifting gears slightly, it's clear from all this that successful outcomes aren't just about the immediate medical stuff, right? Education and the whole system of care matter hugely.
Absolutely, just as much, if not more sometimes. You can have the best science, but if it's not implemented well through training and systems, it doesn't help patients.
So on the education side, what are the recommendations?
Things like using deliberate practice and mastery learning and training, really focusing on getting skills right. Doing booster training sessions to combat skill decay.
Yeah.
Training school-age children in CPR, getting it started young. And a really important focus now on equity. targeting training to specific populations, racial, ethnic, socioeconomic groups, to address known disparities in who gets bystander CPR,
That's critical.
and specifically addressing gender-related barriers. Why are people sometimes hesitant to do CPR on women? We need to tackle that. Plus, training in opioid overdose response and naloxone use is highlighted.
Right, and the systems of care piece.
Recovery is now seen as a critical, integrated link in the whole chain of survival, not just something that happens later if they survive.
Okay.
There are promising developments like using mobile phone tech to alert nearby trained lay rescuers to an arrest. Observational studies suggest this can get help there faster, increase bystander CPR rates, and the absolute importance of data registries. You can't improve what you don't measure. Collecting outcome and process data lets systems see what's working, where the problems are. It's been linked to better survival rates. Oh, and team debriefing after resuscitation attempts. Also highly recommended. Learn from each event.
Okay, so wrapping up our deep dive today, what really stands out is just how dynamic this field is. CPR and emergency cardiovascular care constantly evolving.
Definitely.
We have clear algorithms, sure, to guide those initial actions. But the evidence base, it's got real complexities, real nuances, especially look closely at medications we've relied on, like epinephrine or these newer combination therapies.
Yeah, we've really seen that tension play out, haven't we? Where an intervention might clearly help restart the heart or even improve initial survival numbers.
Right.
But the data gets murky or sometimes even conflicting on whether that actually translates into meaningful survival with good brain function.
And it's just powerfully clear, isn't it? Successful outcomes depend on so much more than just the drugs or the technique. It absolutely relies on widespread, effective training for bystanders and professionals, strong teamwork in that critical moment, and robust systems supporting the patient from the second they collapse all the way through long-term recovery.
Absolutely. So, given the evidence we've walked through today, especially around epinephrine and maybe that vasopressin steroid combo, where we see benefits in ROSC or maybe initial survival, but the impact on saving the brain, ensuring a good quality of life, that remains uncertain or conflicting.
Yeah, it really makes you think, doesn't it? How do we best balance that immediate urgent goal, just get the heart started again, with the equally vital, truly patient-centered goal, preserve brain function, ensure survival is actually meaningful for that person, for their family?
It's the question, isn't it? It drives the ongoing research. It requires really careful, thoughtful interpretation of guidelines right there at the bedside. And ultimately, it just demands truly patient-centered care in every single resuscitation attempt we make.
A challenging but crucial perspective to end on. Thank you for joining us for this deep dive into the evolving world of CPR and emergency cardiovascular care.